Okay, so warm greetings to everyone present. My name is Anoushka, and I am graduating from the TMU Bachelor's of Nursing program this summer. I work as a research assistant under Bridging Divides, and it's under the team of immigrant health and well-being. My research background lies with examining the role of language translation apps and devices for immigrant older adults in long-term and community care settings. I have also had the privilege to work alongside a team of accomplished researchers, such as Dr. Rosie, who did speak today as the keynote speaker, as well as Dr. Yamini here, and my friend Nivashi, who wasn't able to make it here today, but I love her. Today I'm very excited to share about the findings of this rapid review, which explores the current state of evidence on how healthcare providers deliver culturally competent care to South Asian immigrant women during the postnatal care period. Next, please. So this is just a quick agenda overview. I'm not sure I'll stick to it. I'm going to be very honest. But I'll try my level best to. I might just briefly go over the methodology and the results, but I will make sure to include all the important findings in the discussion part. Next, please. Okay, so let's start with this. Postnatal care is deeply cultural. Why do I say this? For many South Asian women, healing after childbirth, it's not just about medications and checkups. It's about rest. It's about warm food that's made with intention. It's about the care of mothers, grandmothers, aunties. It's also about when the whole process of immigration. When they immigrate, they also bring with them a rich postnatal knowledge bank, if we can call it that. For these women, healing is cyclical, it's collective, and it's deeply tied to culture. But our current healthcare system, it still has some roots in Western biomedical paradigm, which tends to primarily give more importance to physical recovery, and at times, it does fail to acknowledge the traditional aspect of healing. And it also doesn't help that South Asian women, immigrant women, are underrepresented in our healthcare research and policy. They make up over 7% of Canada's population, but they're often placed in broad categories like visible minorities, women of color, racialized women. And while these terms, they were built to improve equity, in this context, what they do is they actually erase that specific context and the lived realities of this community and what their specific needs are most importantly. And because of this lack of representation, cultural competence is still very underdeveloped and underinformed for this particular population. True cultural competent care means listening, it means respecting, it means adapting care to meet people where they are, with their language, with their identity and lived experience in mind. Next, please. This is exactly what this rapid review aims to explore. It aims to explore how healthcare providers deliver culturally competent care to South Asian immigrant women and what barriers and facilitators exist in this process. We're looking at both the perspectives of healthcare providers and women themselves to bridge the gap and to identify what's working and where there's still room to improve. Next one, please. Thank you. Okay, very quickly. So to conduct our review, we use the 5-stage modified Arxio and O'Malley framework. It's not really used in rapid review, but to give it more structure and rigor, we decided to go with this. We screened about 431 studies at level 1, but by the end of this review, only 4 studies met our criteria. So clearly we can see there's a gap in research on this specific topic. Next, please. So data extraction. We collaboratively developed teams across 4 areas: healthcare provider perspective, South Asian immigrant women's perspective, and the intersecting barriers and facilitators between them. Next one, please. Okay, very quickly again. But if any of these themes that are listed here catch your eye, we can always pick it up in the question and answer part. But I will report how many studies acknowledged the facilitators and barriers specifically. So all 4 studies that were included reported on the perceived barriers by South Asian women in Western healthcare settings. Next one. In here, only one study reported on the barriers to culturally competent healthcare from healthcare providers' perspective. Next one. One second, my paper. Okay. 3 studies identified facilitators of positive postnatal experiences from South Asian immigrant woman perspective. Next one, please. And 2 studies highlighted provider practices that supported culturally competent care. Next one. Okay. All right, so discussion. This is my favorite part because it's the so what? Like, what do all these themes tell you, right? So, number 1, although language barriers were frequently cited as main issues between providers and South Asian immigrant women, the root causes of this issue, they were more complex than just limited English proficiency. So from healthcare provider perspective, the limited use of interpreters due to organizational constraints such as cost, lack of resources, and time pressures were the main issue. But from South Asian immigrant woman perspective, this went beyond just language. Women who identified with well English proficiency, they were actually more likely to report dissatisfaction with their postnatal care than the ones with poor English proficiency. It was also the fact that they reported they felt rushed during the encounter. They felt this sense of dismissiveness from their providers during the care. So this indicates that the dissatisfaction stems from just more than language fluency. It cannot be just resolved by translation devices alone. Communication styles need to be acknowledged. Organizational time constraints need to be addressed too. Next, there was another significant theme which was about cultural misalignment between the healthcare delivery and the postpartum needs of South Asian immigrant women. In our findings, we noted that traditional practices such as chilia, it's a 40-day postpartum period of rest. Gurti, it's a sweet-tasting ceremony that an elder touches like sugar or something sweet to the newborn's lips. So hopefully they take up after that elder. And also naming ceremonies, these were frequently altered or not done because of existing hospital policies or the lack of inquiries from the healthcare providers. Actually, only 9.2% of the women reported that their providers actually asked them if they wanted to do any postpartum traditions or any practices. Women also reported feeling pressured to resume physical activity prematurely after C-sections. They felt their pain and fatigue was overlooked. Hospital meals like sandwiches and jello, yeah, they were considered cold and did not really align with the traditional expectation of having hot food after giving birth to assist with healing. The issue was not even the fact that the South Asian women were tied to their traditions. In fact, one of the research papers that was included in this research review pointed that Punjabi women specifically and actively sought to modify traditional foods by requesting low-fat versions of it to align with their health recommendations. Hence, the primary barrier in this case suggested to not be the unwillingness of the women to adapt and meet the common grounds, but the healthcare system's limited awareness to engage in this cultural knowledge exchange. Another broad theme that was noticed was that providers had often a limited understanding of different identities within and between Bangladeshi, Indian, and Pakistani groups. So this led to confusion in providers around ethnicity, language, and religion of these communities. There were also instances of misinterpretation of culturally tied behaviors, where women's modesty and hesitation with breastfeeding were often interpreted as being passive, rather than understood as cultural expressions of respect and privacy. Another concern that was noticed was the absence of meaningful culturally tailored engagement strategies to support South Asian immigrant women during postnatal period. So what the healthcare providers noticed that even after providing interpretation and transportation services, there was limited attendance with the community outreach initiatives, and they expressed frustrations with it. But the issue was that instead of reflecting on the design of the outreach model, and the actual needs of these women, their explanations on the lack of attendance revolved around problematic assumptions on women's agencies, and I quote, needing to get permission from their mother-in-law to attend in the first place. And when South Asian immigrant women were asked about these community initiatives, their responses were a lot different. And it pointed out to the checklist style of care presented by healthcare providers, which lacked emotional depth, and it felt rushed. Last but not the least, despite the central role of healthcare providers in shaping postnatal care experiences, our rapid review findings identified a significant gap in literature regarding their input on culturally competent care. Out of the yield of 4 studies, only 2 studies included the thoughts and the standpoint of providers, and only 1 study reported on barriers from their side. So this issue, it actually suggests a deeper problem beyond just a simple content gap. Like, it points to a gap in knowledge production, specifically on who is positioned to define what constitutes good care, whose voices are centered, whose are excluded. Without research that explores how providers conceptualize their roles in delivering culturally competent care, it is impossible to assess whether they're engaging in critical reflexivity during this process. And this also leads to a big gap and this missed opportunity in quality improvement when giving care to this specific population. Next, please. Implications. So now that we've listed all these problems, what can we do to solve them? I feel like this has been mentioned multiple times throughout the presentations by my colleagues. Participatory research style. Number 1, recognize South Asian communities as experts in their own care. If we see an issue, what do? We go to them, we tell them about it, we ask them what can we do to make it better. If they don't have any idea, we probe, we provide certain solutions, see if it fits their models or not. It's just a well-known practice actually showing up in nursing and sociology discipline. And it is known to improve patient satisfaction and outcomes, and also the trust they have with the people who are providing care for them. They feel like, okay, this person is caring for me, they're taking the time to come and talk to me and ask me about what my problems are. We need to divert the narrative to what they need and not what we think they need. Next is also cultural competence itself needs to be redefined. Rather than framing it as a linear checklist of cultural traits or the norms associated with the cultural groups, we need to be actively present in the moment and talk to them and learn through this knowledge exchange about what works for them, what doesn't. Each person is unique even within a specific community group, and we need to treat it as such. Cultural safety training for healthcare providers should also focus more on critical reflexivity and actively learning from their resource banks, which is our patients. However, for such reflexivity to even occur in the first place, more research needs to explore healthcare providers' perspectives on delivering this care, particularly in the context of postnatal care. This next one might take some time to be implemented, but we have to start somewhere. Organizational barriers need to be addressed because cultural competent care cannot flourish under time constraint and a system-driven urgency to clear up beds or rush to the next patient due to unmanageable patient to provider ratio. Most importantly, and my drop the mic moment, there needs to be a reflection on the epistemic values that form the basis of postnatal care. So what do I mean by epistemic values? I mean the rational belief, the knowledge, and the understanding that form the basis of this care. The dominant narrative is of maternal resilience, and such as expecting women to go home within 48 hours of delivery. It can shame those who heal differently. Postnatal recovery, it's not linear, and women should be supported in making decisions about their own healing journeys without judgment or pressure. If early discharge is prioritized, healthcare systems have an ethical responsibility. I know we used that word before, ethics. They have ethical responsibility to ensure women receive adequate follow-up support that is culturally relevant, it's linguistically accessible, and it's delivered through interventions tailored by and for this population. And yeah, mic drop. So these are just some limitations of our rapid review. Next one, just references, and next one. Ta-da, done.